Well, thank you very much for that generous welcome and introduction. I'm really pleased to be back in Canada and back in BC and Vancouver to share some of our experiences around this theme of the triple aim, perhaps to share some of our pain as well, and to learn from you about how you're coping with a really challenging time for healthcare now and in the future, with resource constraints, increasing demands, and the familiar issues that gives rise to. I'm going to speak for no more than half an hour because I'm interested in both the response and the questions that I hope will arise out of what I have to say. I'm going to talk to you in a context of a decade or more in which we've seen massive improvements in the performance of our healthcare system in England. I am talking about England because we have 4 variations on the theme in the United Kingdom of our National Health Service, and the English approach is increasingly distinct and different from that in Scotland, Wales and Northern Ireland. But a decade of investment, a decade of reform, a decade of real improvement around patient experience of care, most obviously sharply reduced wait times, improved access at all points within our healthcare system, together with major investment in high priority areas like cancer care, cardiac care, and patient service users have seen the benefits of that decade of improvement. But that is in the past. We're now in a very different phase for reasons which will be very familiar to you too. So I want to talk about the triple aim. I want to talk about the 3 burning platforms that we're faced with back home. I hope there'll be some resonance, some read across to your experience wherever you work, whether as a researcher, as a policymaker, or perhaps somewhere in the middle ground. You may be, if I can put it like this, you may be a cross-dresser like me, interested both in policy making, have experience in policy making from my time in our health department, but also an experienced researcher and evaluator. So the 3 burning platforms, you'll notice they look remarkably similar because indeed they are the same burning platforms, but they each signify different pressures that I want to briefly introduce. And I want to spend most time on the third of those because for me it is by far and away the most important. But to begin at the beginning, the first burning platform are the funding pressures that we are confronted with. The budget for the National Health Service in England, our single-payer tax-funded system, will be static in real terms for at least 4 years and more likely 8 to 10 years. Because of the well-known financial problems that arose in 2007, 2008, and the response our current government has chosen to take to bring public spending under control, to increase taxes, to achieve a more balanced fiscal position. We're now 2 years in. At an aggregate level, for England as a whole, the system seems to be coping, living within that very tight budget, mainly because of some pretty crude national policies that have been adopted, most notably a pay freeze for 2 years for all staff, including physicians, reductions in the prices that are paid to hospitals. We have a national tariff under which our hospitals are reimbursed, and some of those prices have been cut in real terms over the last couple of years. There's been very tight, some would say prudent, financial management. But at a local level, an increasing number of organisations find themselves running deficits, and those deficits are getting bigger by the day. And it seems that if we're only 2 years into a decade of austerity, then things are likely to get worse rather than get better over the next period of time. At least so far, patient care has not been adversely affected, as far as we can tell, except in one key area, and that is our hospital emergency rooms are under growing pressure. We have a target that all patients should be seen and either admitted or discharged within a maximum of 4 hours in our emergency rooms. Up until quite recently, that target was being met. In the first quarter of this year, the back end of the winter, that target was missed across the country. And our wait times in our emergency rooms are now at the worst level they've been for a decade. And this is only 2 years into a decade of austerity going forward. So a sign of things to come, a sign of pressure to come. We produced this report at the King's Fund 3 years ago. John Appleby, my colleague, was the lead author. I think the subtitle says it all. Our challenge is how do we do more with the same resource, because there is no extra resource going in over and above what's needed to cover the costs of inflation. And that is the issue that our healthcare leaders are more and more focused on. Squeezing out waste, tackling variations in performance, delivering more with the existing envelope of resource and trying to improve value as a consequence, if you like, part of the triple aim challenge that we are all very familiar with. We did a survey of hospital doctors and family doctors in 2010, about the same time we produced that report. We asked them for their views on the best ways to achieve efficiency savings. And you'll see from this response, people were not very enthusiastic about reducing staffing levels, for example. What I wanted to draw your attention to is the two most popular responses to this survey, the two at the bottom. First of all, better coordination of care between different organisations, and secondly, increased collaboration between family doctors, secondary care clinicians, and those running our community healthcare services. And I'll come back and talk about that, because from our point of view, these issues around collaboration, integration, collaboration are absolutely central to how we need to move forward, and I suspect the same may apply to you as well. So that's the first burning platform, the funding pressures and how to respond. The second burning platform relates to this piece of legislation which was put on our statute book about a year or so ago. This is the legislation our coalition government of the Conservative Party and the Liberal Democratic Party have put in place to further reform the National Health Service in England. We are the world champions in reorganising our systems and our structures. And I don't say that with pride. I say that, if anything, with regret, because we reorganise and restructure far more frequently than any other country that I'm aware of. And that has a destabilising effect. It's distracting. It takes time and attention away from dealing with the real issues which I want to come on and talk about. This legislation is a further development of policies to increase patient choice, competition between providers that have been in place now in different forms for about 20 years in England. It's what our former Secretary of State for Health, a man called Andrew Lansley, had been working on in opposition, and when he came into office, he had the opportunity to put his plans into action through this major piece of legislation. A far bigger piece of legislation, by the way, than the Act that established the National Health Service back in 1948. This is what it means: huge organisational change. Many experienced managers have been lost because there's been a cutback in management posts and management costs. The new structures were intended to streamline and simplify. How often have we said this? They had exactly the opposite effect. There's been much more complexity in the organisation of healthcare in England, and the focus has been very much on structures and structures at the expense of services. My colleague, Nick Timmins, has written a very interesting and I think quite exciting account of this exercise, the passage, the story of the Health and Social Care Act 2012. Unusual words to use, perhaps exciting, about a dissection of the process of policy making that led to this major piece of legislation. Nick, by background, was the public policy editor of the Financial Times. He got access to all the key politicians, civil servants and advisors, and he's written a kind of health policy whodunit. How did this piece of legislation come about? What was the process? And who really was influencing its development? I really do commend that. You can download that for free from the King's Fund website if you're interested to read his analysis. So financial pressures, organisational change, further reform, which leads me into the issue I want to spend most time talking about. And that issue is the need for us to think very hard about the services that we currently provide, how fit for purpose they are, and how they need to change to deal with the pressures now and in the future. I've explained already that the performance of the health service in England has improved greatly and I can give you chapter and verse on that if you want to challenge me. Despite that, we would argue at the King's Fund the current model of health and care, social care delivery, is outmoded, and therefore fundamental reform is needed to the delivery of services, not to the funding model, because we would defend the current single-payer tax-funded model as an equitable and appropriate way of paying for healthcare. It's much more around how the services are organised and delivered, where the case for change is compelling. I wrote this paper with colleague Anna Dixon and Beatrice Brooke, which we published 9 months ago, which set out the arguments that we believe underpin the compelling case for change. I'm not going to go through my next few slides in any detail. I'm going to flash them up because I want you to see the facts and figures, or some of them, a selection of the facts and figures we brought together to really justify the argument for fundamental change in the delivery of health and social care. None of this is original. What we've done is distilled facts and figures from a variety of governmental and independent research-based sources to show where there is room for huge improvement in how our system performs. So we drew on the work of Nolte and McKee on mortality amenable to healthcare, showing that we have the second highest rate among 16 high-income nations. We drew on evidence about our cancer survival rates being not as good as the best in Europe, and 10,000 lives could be saved each year if we narrowed that gap. We drew on evidence from the National Audit Office of the gaps in care for people with diabetes. Our National Institute for Health and Care Excellence has produced guidelines on what GPs in particular should be doing to provide the best possible evidence-based care for people with diabetes. There are 9 things in those guidelines that should be done routinely for every patient in every consultation, or indeed through a series of consultations. And they're not done consistently. If they were, you can see the figures. Lives could be saved and resources could be saved as well, if we were able to bridge that quality chasm, if I can borrow a phrase from a different context. Our children's services leave much to be desired as well. Ingrid Wolf and colleagues compared mortality among children in England with, in the United Kingdom with that in Sweden, and showed that if you looked at illnesses that rely on first access care, by which she means illnesses such as asthma and pneumonia, as many as 1,500 children a year might not die if we delivered the same outcomes as in Sweden. And the list continues. I make no apology for this because I really want to lay down the evidence base that underpins the case for fundamental change. The list continues into mental health. You can see the figures there from Richard Layard and colleagues, the LSE, the gaps in care around treatment of people with depression and anxiety. And of course, the main issue there is the quality chasm, but also there are financial consequences that follow as well, waste of resources. There is excess mortality in our hospitals at weekends. We run a 2-tier acute hospital service. The quality of care you receive will generally, not always, will generally be better during the week than it is at weekends, mainly because of differences in levels of senior medical staff in hospitals. There are areas too in relation to our specialist services. I give an example here of stroke care where we've got room for improvement. So in London, for example, the number of hospitals providing hyper-acute stroke care has been reduced from 31 to 8, with lives saved and quality of life improved by the concentration of specialist services for stroke patients in that way. And that's now been extended to vascular surgery, to trauma, and to cancer care as well. We don't have the figures as yet on that. And then my last killer fact, if you'll excuse the phrase, relates more to the standards of dignity and care and nutrition for older people in our hospitals. Our quality regulator, the Care Quality Commission, has produced evidence on this, showing that more than half of the 100 acute hospitals inspected were not compliant with basic standards of dignity and nutrition. I don't know if you've been following the events around the Francis report into mid Staffordshire NHS Foundation Trust, a truly shocking example of failures in basic standards of care for patients in one hospital in the middle of England, which could be added to this list to further provide the evidence that I've been referring to. We have our own version in England, moving on, of the work that Jack Wenberg and colleagues at Dartmouth have done over many years, highlighting variations in care. This is the NHS Atlas of Variations in Healthcare. It's one volume among many that are now being published, bringing together routinely available data, illustrating the scope for reducing variation and moving services more in line with the best available evidence. So I hope that begins to establish the basis on which we make these rather large claims. Now, just in case you're beginning to feel, well, it's not that bad here, let me just show you my next slide. This is the Commonwealth Fund's international ranking, which actually, using the data that they draw on to make these comparisons, shows the UK in 2010 in second position among a group of 7 countries. I shall lead you to see where Canada fits within those rankings. All I did want to highlight here, because I haven't made the point already, is the one area that the UK comes out particularly badly on in this ranking is what's called patient-centred care. And I think we will put our hands up and say, yes, we recognise that. Although we've improved access, we often do not provide care that's truly centred around patients and their needs. The points I'm making here about the challenges in England, I would argue, are pretty universal challenges. However well we think our healthcare systems perform, and our social care systems too, we're still trying to make an outmoded model work better, rather than thinking about how we can change that model to one which is much more high quality, consistent, delivering patient-centred care of the best possible standards within the available resource, if you like, the triple aim challenge. So what needs to be done? What should the future model of care look like? Well, what we've done is to sketch out some of the key characteristics, placing much more emphasis on the role of patients and users in the care team. It was David Sabel from Kaiser Permanente who said to me a long time ago, the most important primary care providers aren't family doctors or nurses, they are patients. They are people receiving care. They are the people who are taking decisions every minute, every day about their exercise, their diet, their lifestyle, which impacts on their health and well-being. We need to do much more to support and empower people in taking decisions about their health and well-being. We need to change professional roles, making much better use of nurses alongside doctors, thinking about team-based care rather than simply medical care. And I'll come on and talk about rethinking the location of care. Back home, we place too much emphasis on care in hospitals, in care homes, in residential settings, at a time when that simply is not sustainable. Last week, I went with our health minister and spent a week visiting a variety of organisations on the west coast of the United States, including Intermountain, Group Health, and indeed Kaiser Permanente. And when you see the impact of information technology, members of Kaiser Permanente having an app on their smartphone, and they can use that app to email their doctor, to make an appointment, to check all their test results. They can send a photograph of the mole on their arm, which is getting bigger, to their family doctor and expect a response within a day or two. That is so far away from where we are back home. And can I do a bit of democracy here? How many of you have an app on your smartphone so you can send an email to your physician? I think I rest my case at that point. So healthcare is way behind, isn't it? With some notable exceptions like Kaiser Permanente and Group Health, what we see and expect in other areas of our lives. And that cannot continue. We need to accelerate the pace of development. We need, in other words, to fix the broken delivery system. For us, what does that mean? We have good primary care in many places, but we would argue primary care does not operate at scale. We need to do what our Royal College of GPs has argued for, get our practices to collaborate through federations and through networks, able to deliver more care out of hospital in community-based settings. One of the problems we have, I've alluded to, is that too often patients default to the hospital emergency room. They do that because generally it's the only bit of the system that's open 24/7, and therefore we shouldn't be surprised. If we want to take pressure off the hospital emergency room, we need to provide out-of-hospital care 24/7 too, to provide an appropriate alternative. We need our hospitals not to be standalone fiefdoms, each trying to be self-sufficient. We need to think of our hospitals as part of a system, a local hospital system, so we can do what I described around stroke care, decide which hospital is best placed to provide the specialist care which will deliver the better outcomes, rather than having inefficient duplication of specialist services, which is so often the case at the moment. We need to see people's home as the hub of care, making use of telecare and telehealth where there's evidence to support that, and doing much more to put nursing and other practical support into people's homes to enable them to live independently for as long as possible. And of course, much, much greater priority for the prevention of illness, not just the treatment of sickness. How often have we said that, and how far are we away from actually delivering it in practice? This is not just the view of the King's Fund. This is Tim Evans, who's the Vice President of our Royal College of Physicians of London. And you'll see here from a newspaper report, the college is also putting its shoulder to the wheel. The college is saying, as a specialist college, closing 1 in 3 hospitals would improve patient care. Not only is the College of Physicians saying that, but Terence Stevenson, who is president of the Academy of Medical Royal Colleges in England, is saying something very similar. The long overdue need to centralize specialist services, and I've talked about an example of that, to deliver better outcomes and better value consistent with the triple aim. And then the Royal College of GPs, and if I can say this in present company, not known to be in the vanguard of radical thinking on the future of healthcare reform, very protective of our current model of primary care. And I understand the reason for that has come out with a very interesting report. You can access this on the college's website, setting out its thinking on how primary care also needs to change, working through federations and networks, working at scale, able to build on the best of our general practice, which is very good, and to deliver a wider range of services through collaboration between primary care teams, not through competition. So the picture I'm beginning to paint here, I hope, is one where almost the conventional wisdom is there is a fundamental case for change. That is now, I think, common currency among many of those who are leading our medical colleges, our healthcare organizations, and who work in health policy research. One of the reasons I think it's common currency is we can see what's coming over the horizon. We can see the impact of aging populations, the good news of far more people living longer and often healthy lives, but an increasing minority not doing so. And these people having not just 1 or 2 chronic diseases, but being affected by multi-morbidity, having complex needs that require a joined-up response between excellent primary care, closely aligned with a variety of specialist services, in our case, often located within hospitals. The disease burden that's storing up around risk factors like obesity and overweight. And again, I don't say this with pride. We are second only to the United States in the prevalence of obesity and overweight in our population. We are seeing, as you are too, an increasing trend towards specialism in medicine, the loss of generalism just at the time when we need that because of aging and because of the changing disease burden. Primary care now ever more important, but primary care as the foundation of a truly integrated health and care system. And, of course, the first burning platform, the financial pressures, adding fuel to the fire of these other drivers of change. That's why one of our priorities at the King's Fund has been to make the case for much greater integration of care. We published this report, and we deliberately called it Clinical and Service Integration, the Route to Improved Outcomes. The benefits of integration, if you look at the examples and the evidence, do not come through organizational change. They come through clinical integration, and they come through service integration around the needs of frail older people, to use just one example. And integration is a means, it's not an end. The end we're trying to deliver is improved outcomes. And there is enough evidence, although the evidence is never consistent, that if you integrate around populations, if you integrate around people who use our health and care services, that can deliver improved outcomes. Who would want to stand here? I invite you to consider and make the case for fragmented care. It's a no-brainer that we ought to be moving towards much closer integration, clinical and service integration, if our ambition is to deliver improved outcomes. And that, to come back to the point and the theme of your conference, really does, I think, underpin the triple aim. We need what we call a whole system approach in England, which encompasses not just different aspects of the medical care system, but extends into social care as well, providing practical support to people in their own homes, bringing health and social care together around those who have the most complex needs in that population. Doing what a man called Derek Wanless described 10 years ago as fully engaging the population in acting on the determinants of health and illness, the risk factors that in future will threaten to sink our publicly funded health systems unless we're more successful in addressing those risk factors. And the question I want to come on to, and as I reach the end of my presentation, is, well, if this is the argument, and none of this is entirely new, and we claim very little originality for the work we've been putting out there, the big challenges are, will it be different this time round? How do we move from where we are to where we're arguing we ought to be in future? The challenge really of making change happen. What's the menu of options look like? Well, healthcare systems do change, they do improve, there's no doubt about that, there's good evidence to support that assertion, but they change rather slowly. There is an inertia built into healthcare systems that we have to tackle to produce change and improvement more quickly than has been the case in the past. We need to stop doing things which no longer have value, to decommission, if you like, outmoded models of care. The best example we have back home is the transformation in our mental health services over many years, away from the big institutions towards much more community care. We need to extend that learning into other services than mental health, to our acute services, to shift the care towards primary care and the community. Some would argue we should be much more open to new models of care that new providers can bring in as the emphasis on choice and competition continues. I would certainly support the argument that we need to train and develop staff working in our existing providers to innovate. Very much struck by how Intermountain Healthcare, visited last week, has over many years invested hugely in training its staff in quality improvement techniques and tools, borrowed from the IHI and from other organizations too. There's a whole toolbox there which I don't have time to go into. But if we support and train people delivering care to innovate and to improve, that is a very important route into making change happen. Supporting clinical and managerial leaders and encouraging our politicians to be less risk-averse, to support innovation knowing it will not always succeed, accepting honest failure as the price for the transformation in care we need to bring about. And I would say this is a challenge for us as health service researchers too, to give more thought, not just to the models of care we need in future, but about how we're going to make the transition from where we are to where we need to be, understanding the barriers, but also understanding the facilitators. And the work that people like Ross Baker have done on the journeys that high-performing healthcare systems have been through is, for me, a model of what we need more of in future. Getting underneath the surface, opening up the bonnet, looking at the dynamics of change and indeed of non-change within our healthcare systems. This is where I want to end. We are, if I can give you a a heads up on this. We are about to launch a major piece of work that we will be undertaking over the next 18 months, feeding into the election debate, which will start back home in the autumn of 2014. We're launching a commission to consider the future of health and social care, to revisit the post-war settlement established in the late 1940s that created the division between the publicly funded national healthcare system and the social care system, which is means-tested, which is not universal, which is not comprehensive, and which increasingly feels to be anomalous in a world where people require both health and social care. Are these arrangements still appropriate? 65 years on, almost certainly not. And if not, what are the alternatives? Big questions about how we can adequately fund, what the entitlements to care should be, and how those services should be organised on the principles of a national service, such as our NHS, or more on the principles of a local service, which is what social care is at the moment. And we don't pretend there are any easy answers to those questions, but they're exactly the questions we feel need to be asked if we're going to confront directly the very tough challenges that we're faced in the context of those three burning platforms. Thank you very much.